All right, assalamu alaikum, everyone. This is Mariam Hussein again, the Vice President of IMANA. Thank you all so much for joining in on this next installation of our webinars. So, Bismillahirrahmanirrahim. On behalf of Dr. Amber Khan, who's the chair of our education committee, I'd like to welcome you to this talk on hematologic malignancies, our educational webinars about different topics, health topics related to the community, and also with a special focus on COVID this time around. Unfortunately, we're seeing a second wave of COVID throughout the country. And it's affecting a lot of people in a lot of communities. And so we want to make sure that we're providing you the most up-to-date information from our experts. And so I'm very excited to introduce and moderate this session, especially with these two speakers. Both of these ladies are wonderful, and I've had the pleasure of being able to work with them, and they've been my attendings for the last year. So without further ado, we'll get into the conversation. So our first speaker is Dr. Maria Chaudhry. She's a hematologist, and she specializes in the treatment of patients with plasma cell disorders and other blood cancers. She received her medical training at King Edward Medical College in Pakistan, and then completed her residency at SUNY Upstate in New York. She also completed 2 fellowships at Georgetown University in DC and at MD Anderson down in Houston. And in addition to treating patients at the James, where she and I work, she also works as a clinical investigator and collaborates with other scientists in the lab to develop novel therapies for one of those plasma cell disorders, multiple myeloma. Her research focuses on immune cell subsets that provide an environment for tumor evolution and progression. And she's currently working to develop therapies that can target myeloma at early stages in the hopes of curing this disease, as there's currently no cure for it right now. So without further ado, Dr. Chaudhry.
Thank you so much for the kind introduction, Mariam. And thank you so much for inviting me to be here today. I'm very excited about this talk. So without waiting, I will start. So the agenda for my talk today, my specialty is multiple myeloma. So I will talk about multiple myeloma. I will briefly mention how we treat multiple myeloma, and I will touch on COVID-19 as well with focus in multiple myeloma patients. Okay, so moving forward, what is multiple myeloma? So multiple myeloma is a form of blood cancer. It's a blood cancer, but it can affect bones and can cause fractures in the bones and can cause tumors in the bone. So a lot of people think that it's actually a bone cancer, but that's not true. The cancer arises from the bone marrow. So it affects different organs in the body. So the clinical definition of multiple myeloma is that it is a cancer that arises from clonal plasma cells. A plasma cell is a cell of origin of this cancer, and these cancer cells infiltrate the bone marrow and they cause organ damage, kidney damage, as I said, bone tumors, bone fractures, increased risk of infections and all other complications. And these cancer cells produce an immune protein that circulates in the blood and causes a lot of problems, including renal problems. Multiple myeloma is a relatively rare cancer. It constitutes about 1 to 2% of all cancer diagnoses. It is the second most common blood cancer, and about 32,000 people are diagnosed with multiple myeloma in year 2020, and about 12,000 people died from multiple myeloma. This cancer, which is again a blood cancer, it affects mostly people who are elderly. So median age of patients who develop multiple myeloma is about 68 years. So how is this type of blood cancer different from some other forms of blood cancer that you might have heard of, like leukemia or lymphoma? We differentiate all these types of cancer based on the cell of origin, which means that where did this cancer start from? So we have these stem cells in our bone marrow. Bone marrow is the blood in the bone. These stem cells are like progenitor or mother cells. They produce different types of cell lines for our blood. These cells that these mother cells produce, they go through different stages of maturation. Sometimes abnormality happens in one of these cell lines and cancer develops from that cell. For example, lymphoma is a cancer that arises from lymphoid cells or lymphocytes. Leukemia arises from myeloid cells. And plasma cells, which is a mature form of white cells or immune cells, develop multiple myeloma. Most of these cancers, including multiple myeloma, are diagnosed by biopsy. Like any other form of cancer, we have to confirm. And in order to confirm, we need a tissue. And tissue is the area of the body that is infiltrated or affected by the cancer. So multiple myeloma is diagnosed by doing a bone marrow biopsy. So again, bone marrow is the blood that is present in the bones, and it has a progenitor or mother cells, and the cancer cells also infiltrate the bone marrow. The easiest area or most accessible area to get the bone marrow is from the hip bone, and it is done from the back, from the pelvic area. On the right side, there are a lot of blue cells. So this is what we see under the microscope, small blue cells infiltrating bone marrow. So what are the diagnostic tests that are done initially to screen this cancer as well as to follow along? So as I said, these plasma cells are mature white cells that are present in the bone marrow. They produce this immunoglobulin, which is a part of our immune system. Immune system is what helps us fight infections, stress, and things like that. So these cells produce this immunoglobulin that circulates in the blood. There are different types of cells. All these names are very scientific, but essentially all these tests look at that protein in different ways. Okay, whenever we use the word M, monoclonal, monotypic, it means one type. So it's almost always cancerous. So there are different types of tests that are done to diagnose this, to initially screen this cancer and then follow along. A scientific name of these tests are serum protein electrophoresis, immunofixations, immunoglobulins, and light chains. Okay, so again, these are all the tests that your oncologist or doctor will do to screen for the cancer and then follow along. In terms of imaging, cancer cells are in the bone marrow and they grow in the bone marrow and can form tumors and cause bone fractures. So X-rays are done as well as some other specialized imaging like PET scan or MRI to look at the bones more closely and to see if the patient has any tumors or hole-like areas in their bones. So what are the symptoms of this form of blood cancer? So the cancer cells, as I said, they're in the bone marrow, which is in the bones. So these cells can grow in the bone marrow. They cause the suppression or decreased production of other cells in the blood, which leads to anemia, which is less number of red cells in the blood. It can suppress other immune cells like plasma cells and B cells and decrease the production of other immunoglobulins and increase the risk of infection. So patients suffer from infections. They cause electrolyte imbalance in the blood, and they can cause damage to the kidneys. This cancer, which is multiple myeloma, is an incurable cancer. So the treatment is essentially to improve the symptoms and prolong the life of the patient. So the next question, once we diagnose myeloma based on some blood tests and bone marrow biopsy, how do we treat multiple myeloma? If you look online, there are a lot of medications, a lot of drugs that have been approved for multiple myeloma. Over the last 10 years, more than 10 drugs have been FDA approved. About 15 years ago, we were treating this cancer with a traditional chemotherapy, which is like cytotoxic chemotherapy. But now we have medications that are more targeted towards the cancer cells, myeloma cells, and relatively well tolerated. So once the patient sees their oncologist, they get the treatment, which for their phase of disease is the standard of care. So this is the current treatment landscape of multiple myeloma. It's not a curable cancer. It cannot be cured, but it can be controlled. It can be treated. There are a lot of drugs available. So once the patient is diagnosed, the patient, like any other incurable cancer, is started on a treatment. They get their treatment for a certain period of time to control the cancer in the body. But the natural history of myeloma is that at some point it will progress. When it progresses, then we switch to next line of therapy. Every time the cancer progresses, the benefit becomes smaller and smaller and smaller. Patients who have what we call standard risk multiple myeloma these days have median overall survival, which means most patients live up to about 8 years, which is pretty good. I will mention clinical trial here because if you remember, I just said that over the last 10 years, we have more than 10 drugs that have been approved for the treatment of patients with multiple myeloma. When the patients were diagnosed in year 2007, we were telling them they had average or median overall survival of up to 3 years. Today in 2020, we are telling them their median overall survival is up to 8 years. Why is that? Because we have better drugs, we have better treatments. Why do we have better treatment? It's because of the clinical trials. We study the drugs, then we test the drugs in the patients, and then we come up with the better treatments. So that is why clinical trial is always important. I will explain in the next slide what are the different phases of clinical trial. But whenever for any disease you are diagnosed, for example, cancer and other diseases as well, diabetes or any other diseases, always ask your doctor if there is a clinical trial available. I always stress on cancer because this is the only way we can improve treatment and eventually get to the cure. So here you can see the picture, the diagram shows that 1 in every 3 people in the US will develop cancer in their lifetime. The focus of the research is essentially to cure the patients who are developing cancer, but eventually try to find out why patients get cancer and prevent it from happening. Okay, so whenever a patient is enrolled in a clinical trial, they see a group of people, which includes oncologists and other staff members who help patient as well as an oncologist to go through the clinical trial. There are different phases of clinical trial. So whenever a patient is offered a clinical trial, they should always ask, what is the phase of the trial? Okay. And what is the benefit to the patient and what is the benefit to the research community? So clinical trials, again, it could be a drug, it could be a test. Clinical trial is always done in different phases. The first phase is always phase 1. Phase 1 is early phase clinical trial. It includes a drug, a medication that has never been tested in humans before. The investigators think that this drug will work because of some what we call preclinical data. There might be some animal studies, there might be studies in different cell lines, and there is an idea that probably this drug will be effective. So essentially, phase 1 trial is for the patients who have no other option available. And the purpose of the phase 1 trial is to see if this particular drug or medication is safe in humans. Once a drug passes through phase 1, then it enters the phase 2. In phase 2, the drug that we know is safe. Now we enroll more patients to see if the drug is actually effective. Okay, so there are more patients who are enrolled in the phase 2 part of the trial. Again, phase 2 is generally for the patients who do not have any other standard of care or better therapy available. Once a drug shows efficacy in the phase 2 part, then it moves towards the phase 3 part. And in the phase 3 part, the drug that we know is already effective, we compare it to the standard of care, which means the available drug that the patient is going to get. These drugs are compared head to head. Depending on the results of the phase 3 trial, the drugs are approved if they are effective and if they are safe. Okay, and at that time, FDA looks at the data and the drug is approved and is available for the patients outside of the clinical trial. And phase 4 is when the drug has been prescribed in the community, a pharmaceutical company and oncologists and FDA follow and make sure that there are no unexpected toxicities or side effects happening in the community. So these are all the phases of the clinical trial. Again, it's very important, especially in diseases like multiple myeloma, which is incurable. In order to bring better therapies, clinical trials are needed. Okay, so last slide is especially talking about COVID-19 in patients who have multiple myeloma, again, a form of blood cancer. Like most other cancers, multiple myeloma patients are immunosuppressed. When I say immunosuppressed, it means that they do not have the immunity or ability to fight infections, okay? So the immune system is suppressed not only from the cancer, but also from the chemotherapy. And also the patients who develop cancer are mostly, the median age for most of the cancer is more than 60. So patients are elderly. So all of these together makes these patients prone to catch infections and have bad outcomes from infections. So there are different studies and outcome studies that have been published in the last few months. So I have here written the percentage of patients who have cancer and have died from COVID-19. This means that the patient already has a cancer. Patient can have a end-stage cancer, or patient is on chemotherapy, but he developed COVID-19, which was the cause of mortality for this patient, cause of death for this patient. So the number is variable. The 8.3% risk of death in New York, 7.6% in China, 20.3% deaths in Italy. And there was a study that was just published a few days ago, which looked at the outcomes and identified the risk, especially in patients who have multiple myeloma and who develop COVID-19. So it's an international study that included about 10 cancer centers, some in Europe and some in North America. And they saw that about 33% of patients who had multiple myeloma and developed COVID-19, they died. Okay, most of the patients, again, who died were the ones who needed ventilator support, which means their breathing and their lungs were so bad that they needed help and machines to breathe. So the risk of death is much higher in multiple myeloma patients who get COVID-19. And in that study, they found that the risk factor for death in these patients is, again, age, patients who have cancer that is uncontrolled, and who have kidney disease. Again, as I mentioned, progressive or uncontrolled cancer is the risk factor to have bad outcome from COVID-19. Because there is an ongoing pandemic is not a reason to treat the cancer. Actually, patients who are on treatment, whose cancer is under control, had better outcome if they are to contract COVID-19. So moving forward to the last summary slide. So again, as I said, multiple myeloma is an incurable cancer. It's a blood cancer. It can cause bad symptoms. It can cause fractures, infections, kidney failures, and anemia. Patients are treated to prolong life. And as I said, one message from this talk, always ask if the clinical trial is available at cancer center near you. It will help you. You'll be able to get better drugs that are not FDA approved yet, as well as it will help the patients who will develop cancer later on as well. And the patients who have cancer are at high risk of complications from COVID-19 itself. So you need to stay very, very safe. This is the end of my discussion. Thank you so much.
All right, awesome. Thank you so much again, Dr. Chaudhry. That was really great. Just in the interest of time, I want to ask you just a couple of questions, but so just so that people know too, in case they have questions about, what to look out for, are there any warning signs of multiple myeloma?
So it's usually pain. The symptoms are pain, uncontrolled pain. There is no specific trigger, fractures without significant trauma, feeling fatigue, tired, weight loss, infections, bad infections again and again, and kidney problems. So any of this happens, there can be multiple other reasons that can cause this. But again, your doctor should always have multiple myeloma in the back of their mind.
Okay. So it's really important for people to go to their doctor, primary care, whoever, if they're having any sort of concerning symptoms. And then one of the other things too, that we always hear that patients are worried about bone marrow biopsies, right, and going through the procedure. Can you give a little insight as to if patients should be worried about it, what should they prepare for, or if it's actually not that bad of a procedure as they think?
That's a very good question. So bone marrow biopsy is always ordered by an oncologist, and there is always a reason to do it. It is always done either by an oncologist, a doctor, or a mid-level provider like a nurse practitioner. It sounds brutal, it sounds painful, and it actually is, but it's not a high-risk procedure at all. Because the area that is used to puncture the bone does not have any big nerve or a blood vessel close by. So the procedure itself is very low risk. The way we do it is done from the posterior or back of your hip. The provider is going to numb the skin nicely with a needle, then put the needle inside and numb the area around the bone. This will be followed by insertion of a relatively bigger needle in the bone and digging a little bit deeper to take a small piece of bone and blood. It's usually not a lot of pain, but it's usually a feeling of pressure. You can get some pain medication and medication to relax yourself before the procedure. The risk of complications like bleeding and infections is extremely, extremely low.
Awesome. Thank you so much again. We'll move on to our next speaker as well. And so looking forward to it as well. So Dr. Seema Bhat, she's a hematologist as well at Ohio State, and she specializes in another type of hematologic malignancy called chronic lymphocytic leukemia, or CLL. She has served as a principal investigator on a number of clinical trials, like what Dr. Chaudhry was talking about, and also collaborates with other lab scientists as well to develop novel new therapies for CLL. Her research interests include developing novel targeted therapies for the treatment of CLL with the goal of curing this disease. The goal of curing the disease without the need for chemo, as people currently may need to require it. Her aim is to improve the quality of life for these patients so that they can lead a normal and productive life without enduring the toxic effects of treatment. In addition to her clinical work, she's an assistant professor in the Division of Hematology at Ohio State, and she has served on a number of national committees, including the National Cancer Center Network, guidelines panels for cancer and chemotherapy-induced anemia, CLL, and another type of it, small lymphocytic leukemia, and hairy cell leukemia. Give us some insight into CLL, so Dr. Bhat.
Thank you, Mariam, for that kind introduction. And Assalamu alaikum, everyone. Thank you very much, IMANA, for what you do, for your service. And I am really excited to be here talking at your webinar. So as you heard from Mariam, I am a hematologist, not a COVID doctor, but we do see COVID in our patients with blood cancers. And COVID in general has affected every aspect of cancer. So I'll talk about COVID and cancer, relation of COVID and cancer in general in cancer patients, but focusing on patients with blood malignancies or blood cancers. Sorry, I'll have to ask them to move my slides next. So I'll be dividing my talk into 3 groups. First, we'll talk about when cancer patients get COVID. We will talk about the impact of COVID pandemic in general in all patients with cancer, and then some good news, because we don't want it to be all depressing. We'll talk about some good news from the cancer world, some cancer therapeutics that can be used for COVID-19. So Dr. Chaudhry gave us a good introduction about risk of COVID in patients with cancer. As you saw, patients with multiple myeloma, they have an adverse outcome. So we all talk about COVID and COVID being more intense or more deadly in patients with certain comorbid conditions. So this came out from a joint mission between WHO and China very early in the pandemic. They were trying to set up this mission with a goal to understand the disease, to share knowledge, and to develop strategies to counter this. So they collected data on a number of patients, and they saw that the outcomes were worse in certain categories, like patients with you all have heard about these, cardiovascular disease, diabetes. These are patients more prone to adverse outcomes from if they get COVID, hypertension, respiratory disease, and cancer is up there. So it is one of the risk factors for an adverse outcome if a patient gets COVID. So actually, this also came from Wuhan. They looked at about 205 patients with different kinds of malignancies, included solid tumors as well as blood cancers, who had lab-confirmed COVID. What they saw was that 1 in 4 patients, 25% of the patients with any kind of cancer, develop severe pneumonia. And of patients who are admitted to the hospital with COVID, 1 in 5 die, about 20% mortality. When they looked at different kinds of cancers, they found out that blood cancers or hematological malignancies had a worse outcome compared to solid tumors. Some other factors they looked at was male gender, that also had poorer outcome, and if a patient had received chemotherapy within 4 weeks prior to the onset of symptoms. So heme malignancies, male gender, and chemotherapy within the 4 weeks prior to the onset of symptoms were considered as high-risk groups. So as you can see in this, these multiple graphs on the right side of the slide, the top one compares death, ICU admissions, severe or critical illness, or invasive ventilation, being on a breathing machine, in cancer patients versus non-cancer patients. The orange yellow bar is for cancer patients. You can see all outcomes, ICU admissions, ventilator, death, are worse in patients who have cancer compared to patients who don't have cancer. That's blue in the top graph. In the next graph, you see the outcome based on different kinds of malignancies. As you can see, the purple graph is for heme malignancies or heme cancers or blood cancers that has a worse outcome. The next in line is lung cancer because COVID predominantly affects the lungs, causing pneumonia. Going down the graph, you can see right at the bottom, I'll leave the middle two. At the bottom, you can see outcomes of patients who get COVID and cancer based on what they're getting for their cancer. Surgery, immunotherapy, chemotherapy, or radiation, or no therapy, or targeted therapy. You see patients who get targeted therapy, that's in orange, they have better outcomes compared to patients who get chemotherapy or surgery or immunotherapy. So outcomes do vary, as Dr. Chaudhry also alluded to, based on what kind of treatment they are getting or whether they are getting any treatment or not for their cancer. Another study which showed worse outcomes in cancer patients who get COVID, another study showing that actually blood cancer patients have a worse outcome. Patients whose lymphocytes are low, chronic lymphocytopenia, or they're on corticosteroids for whatever reason. Most of the patients with blood malignancies, lymphomas, myelomas, steroids are part of the therapy and are used on a chronic basis. That leads to a poorer outcome. Also surprising here is in solid tumors, where you use what are the newer class of agents called immune checkpoint inhibitors. You may have heard drugs like Opdivo, nivolumab, pembrolizumab. Those patients also have a poorer outcome if they get COVID. So we know from all these studies that patients with blood cancers have a poorer outcome. But how poor is the outcome? So this is one of the most robust data alluding to that. This came from a retrospective study from Italy in about 536 patients. Of these patients, only 16% were treated as outpatient, meaning that the vast majority of the patients, 4/5 of the patients, 84% of the patients needed admission to the hospital. The mortality rate was very high, as Dr. Chaudhry said, 33% in myeloma patients, 37% in patients who have any kind of cancer. So if you see of the different kinds of cancers, blood malignancies, there are different kinds. There are certain malignancies which have a worse outcome compared to others. For example, acute myeloid leukemia, or some indolent lymphomas, or even aggressive lymphomas, or multiple myeloma, as Dr. Chaudhry just talked about. Coming to the disease that I treat, CLL, actually, we had data on about 200 patients. This was a retrospective international study, data on about 198 patients from 43 centers worldwide. They saw that patients with CLL, whether they were on treatment for CLL or not on treatment, the disease was stable or this disease was active, if they got COVID, 90% of them were hospitalized. And the mortality rate here was also very high, 33%. And on the left side, you can see, as I already mentioned, whether they were on treatment or never treated or ever treated, the outcome was similar. It did not matter if they were on watch or wait. Sometimes we do that for our patients, or they were on active treatment. Another important thing that came out of this study was that we talk about targeted agents being safer for our patients with blood cancers. They found out that these patients who were on a kind of targeted agents called BTK inhibitors, Bruton's tyrosine kinase inhibitors, Ibrutinib or acalabrutinib, their outcome was similar. But there is a caveat in this study that most of the patients who ended up getting COVID were on a BTK inhibitor. Their BTK inhibitor was held at the time they were admitted to the hospital. Why am I mentioning this is we'll discuss this later on as I go through my talk. But this data is actually being updated. This was very early on when the pandemic started. This data was collected. We have, as the pandemic has progressed from, for example, March to June, the outcomes may have been worse compared to we learned, we evolved, we put measures in place. So moving forwards, maybe the outcome in our patients looks somewhat better because we have kind of learned to deal with this disease somewhat. So bottom line, cancer is a known risk factor and it is exacerbated by either patient-related factors, again coming to those comorbid conditions, older age, comorbid conditions, hypertension, diabetes, lung disease, and some cancer-related and cancer treatment-related conditions. Most blood cancers are inherently associated with some immune dysfunction. They don't have adequate immunity. And that immunity is even further suppressed by the treatments that we give for this cancer, immune suppressive chemotherapy. Most of the cancers, both solid tumors and heme malignancies, are associated with an increased thrombosis risk. That means clot forming risk. And we have heard this all over the media, all over talks, that COVID-19 patients are prone to develop these clots, which can lead to an adverse outcome. And I do want to mention a little bit about the drug that we use very commonly in heme malignancies, especially the lymphoid malignancies, rituximab. It's a monoclonal antibody, very safe to use. However, it does have some suppression on immune system, which can be both acute and chronic, which can lead to worsened outcome in patients who get COVID. It also has implications for hopefully the upcoming vaccine. We know that patients who get rituximab, they are not able to mount a good vaccine response for about 6 to 9 months. So keep that in mind when you are prescribing rituximab for your patients. If we are anticipating a vaccine in the next coming months, should these patients be getting the rituximab or not, because it can hamper the effect of that expected vaccine. So things to keep in mind. So this is actually an ASH research collaboration worldwide, where they're keeping track on a dashboard of different cases, both hematological malignant and non-malignant cases all across the world. And if you go on this website, you will have all kinds of data related to gender, race, outcomes based on comorbid conditions. So it's a very good resource, and hopefully we will learn more about the disease conditions as we learn more and collect data on this dashboard. So moving to the next point, the effect of COVID on cancer in general. So we know that COVID caused us to go under lockdown. We slowed down, we closed our clinics, we made adjustments. However, cancer did not go into lockdown. Cancer continued, and cancer, as you know, it's ruthless, it's relentless. It continued to do what it usually does. So that has led to some challenges because of whatever adjustments we had to do, and rightly so, because it happened, nobody was expecting it. It happened as an emergency, so we had to protect our patients, our staff, everyone. So we made some adjustments. Routine procedures were delayed, routine screening was delayed. Because of that, follow-up of any suspicious lesion that was found on screening, that was delayed. Routine visits to address symptoms from patients which could have been suspicious, that was delayed. This all led to delayed treatment, and delayed treatment, leads to increased mortality. Surgeries, radiation, chemotherapy, we adjusted. We went from standard chemotherapy or standard treatments or standard recommendations to non-standard recommendations. For example, for a patient with breast cancer where surgery is recommended, we try to delay surgery by doing neoadjuvant chemotherapy before surgery, and to just postpone that surgery that was immediately needed. And all these non-standard procedures will eventually lead to increased mortality. So that's the effect on disease itself. Now, the pandemic had, besides the effect on the disease, it had effect on other socioeconomic parameters. People lost jobs. Many people lost their insurance. Underinsured, underserved populations were mostly affected by COVID. So that all combines together to compound the effect of COVID that patients with cancer will have. And we will see that as we move forward. So as I already said, screening was hugely affected because screening is considered mammograms, colonoscopies. These are considered routine procedures. These are not emergent procedures, and these were all delayed. You can see colonoscopies decreased by 90% between February to end of April. Mammograms decreased by 87%. So this all led to many missed diagnoses. That it was projected that in the initial 3 months of pandemic, about 80,000 diagnoses were missed because of all these delayed procedures, or not paying attention, or delaying seeking attention for any symptoms. So this is a huge, it's a big deal for cancer. So actually this study, it's not a COVID related study, but it came out timely. I think it came out last week, published in BMJ. This study highlights the effect of delayed treatment on cancer mortality. So they looked at about 34 studies across 17 different kinds of cancers. And these were mostly solid tumor cancers, breast, colon, bladder, head and neck. And they saw that the standard treatment recommendations for these kinds of cancers, like surgery, radiation, or adjuvant chemotherapy, for example, for colon or breast cancer, if there is a delay, it leads to an increased death, increased mortality. For example, you can see at the bottom of the slide, every 4-week delay leads to increased mortality. 8-week delay leads to further increased mortality. 12-week delay leads to even further increased mortality. So this is a very sobering slide because, in the last couple of decades, we had, especially in the last 2 decades, we had made strides against cancer. The outcomes of cancer had improved so much. And if we have this setback, it's really going to push us back, as can be seen in the next slide. So this is what's projected for 2 very common kinds of solid tumors, breast cancer and colorectal cancer. Hopefully, when the pandemic ends, hopefully it will end, it has to end at some point, we will be dealing with the after effects of the pandemic. So this is projected for the next 1 decade. You will see the mortality rate from the breast cancer, colon cancer go up in the next couple of years. And it will take about a decade to go back to where we were at the beginning of this year. So it's a big deal. It's really a big deal. And we do have to get our act back together. Yes, we are in pandemic, but we are 9-10 months into it. We have to brace up. We do not have to lose whatever we had gained from our prior progress. So this reflects that the COVID weighed us down. It impacted not just cancer, every aspect of medicine, but now we have to get back together. Hopefully, inshallah, we'll have effective treatments, we'll have a vaccine, we'll have newer therapies for COVID. We just heard a few days back about the neutralizing antibody, which got an emergent approval from FDA. We will continue to impress masks, social distancing and all. As much as we are focusing on the virus, please do not neglect the disease. Whether it is cancer, that's my topic today, or it's cardiovascular disease, or it's diabetes, do not ignore it, because these diseases, if we ignore them or let loose on them, they will have snowball effect down to years from now. We will be playing a catch up. So we have to brace up. We have to devise mechanisms so that we can address this as well as we are dealing with a pandemic side by side. So what can we do to catch up or have our patients get appropriate care while we are also protecting them from COVID? So there are lessons that we have learned. For example, for oncology patient care, should we delay therapy? There are certain diseases, for example, the disease I treat, CLL. If they have no disease-related symptoms, we can delay treatment for those patients. But then there are diseases like multiple myeloma, Dr. Chaudhry talked about, or acute myeloid leukemia, where you cannot. You have to make appropriate measures put in place so that those patients who you have to treat, you have to give chemotherapy, but at the same time, you counsel them, you teach them, you put measures in place so that they're not exposed to COVID. Oral versus IV, these are for diseases where you have that option. You have an option between oral and IV. For example, hairy cell leukemia. There are certain oral options compared to the purine analogs, which are highly immune suppressive. So at this time, to tide over the COVID period, we can use oral therapy compared to the IV chemotherapy. Discussed regarding elective, we already discussed that. I think we are beyond the immediate critical period of COVID when it initially started. By now, 10 months into it, we should have measures in place so that we can address this. Then infection control, you know all about this, triaging patients, visitor limitation, we have that all over. Hand hygiene, social distancing, you know all about that. Inpatient versus outpatient care, we all put measures in place. We, at our institution, are not allowing any visitors. Rounds for consult services, we started e-consults, reviewing charts, or even providing iPads to patients and doing like FaceTime chats with them. limit team members. I used to do walk rounds with my residents. We all love teaching, but since the pandemic started, we have not been doing that. Even for table rounds, we have limited the staff, social workers and all. We have allowed them to join us remotely. So all kinds of things, preserving PPE, the Battelle, they helped us with re-sterilizing the masks that we use. So all those were put into place so that we could tide over the initial part of the pandemic. Again, outpatient, we have triage in place. Patients are counseled if they have symptoms, they should not be coming to general patient care area. Again, social distancing, limiting patients in waiting rooms, limiting visitors with patients. Hopefully that will help us. In our hospital, actually, we have reviewed, and given all these measures that are in place, our in-hospital transmission rates are very, very low, thankfully. So these measures do help. They do prevent infection. So this is, again, we are moving into the second wave. Hopefully we won't ever have to make these decisions. We heard stories from Italy when the pandemic initially started, rationing, talking to patients about their goals of care, utilizing resources appropriately, and then thinking about our co-workers, healthcare workers. We're all stressed. We have to take care of our families. We have to work. We have to take care of patients who have COVID. We signed up for this. We became physicians for that reason. And we all love to do what we do. But at the same time, this is a very stressful situation. We all have families. We deal with childcare, sick family members. So reach out, talk to each other, be there for each other so that we help each other out through this pandemic. So we already talked about this, delaying therapy. These are some of the recommendations from the American Society of Hematology. Wherever you can do watch and wait, you should do. Wherever you can use oral therapy, you should try to use that. Minimize clinic visits and use growth factors and prophylactic antimicrobials as much as possible for patients with hematological malignancies. So coming to the good news from the world of hematology, using some therapeutics that we use in blood cancers, can they be effective against COVID? There is this drug called Ibrutinib, which is approved for multiple different kinds of heme malignancies. One of them is Waldenström's macroglobulinemia. And actually, they looked at 6 patients, and out of those 6, 5 patients who were on the full dose of this medication, when they got COVID, they did not experience any dyspnea, required hospitalization, and they recovered very quickly from COVID. There was one patient who was on a lower dose. He or she progressed to develop bad COVID and required hospitalization. Ibrutinib was actually held because patient had bilateral CT scan changes, developed low oxygenation, needed supplemental oxygenation. So by day 5, since the patient wasn't getting better, Ibrutinib was restarted and got some other COVID-related medications like tocilizumab with improvement. But by day 10, he worsened and required ventilation, was put on the ventilator. Ibrutinib dose was increased, and within 24 hours, they saw improvement in all parameters and actually was discharged fairly quickly thereafter and recovered well. So actually, BTK inhibitor, besides being approved for different malignancies like CLL, Waldenström's, mantle cell lymphoma, different kinds of lymphoma, it is actually also approved for a condition which happens after an allogenic transplant called chronic graft versus host disease, which is an inflammatory condition. And based on that, we know that it has anti-inflammatory properties, and those could be the properties that are in play in patients who develop COVID, because we know COVID patients mount a very massive immune inflammatory response leading to all those complications that we see in them. So this is basically the mechanism by which it does. This is the molecule that the BTK inhibitors block. And due to the blockade of these molecules, some of the inflammatory markers are reduced. We all have seen IL-6, TNF-alpha, all these markers, which if they are increased, cause lung injury. These markers are reduced. So this is the rationale behind using these medications for COVID. I'll quickly move through this. This is another BTK inhibitor called acalabrutinib. It was used in 19 patients who got COVID for about 10 to 14 days each, and led to improvement in most of those patients who got the acalabrutinib. Based on these small series of patients who did well with ibrutinib and acalabrutinib, clinical trials, Dr. Chaudhry discussed clinical trials in detail. We have nationwide, and we also have at OSU certain clinical trials with these agents available. For example, there's one with Ibrutinib in patients who get COVID with reduced oxygenation or who do require oxygenation, where we are seeing there how many patients remain alive without respiratory rate failure on day 28. Similar study with another BTK inhibitor, acalabrutinib, and another BTK inhibitor, zanubrutinib. So there are numerous studies. You will be able to find one around where you live. So please try to refer your patients for these studies so that we can improve treatment and outcome of our heme malignancy patients who do get COVID. So that's about it for heme and COVID. These are some resources that are available. You can use them, American Society of Hematology, and here are the websites: American Society of Clinical Oncology, CLL Society, NCCN, CDC, FDA, and NIH. There are numerous resources all around the internet if you go to these websites. Similarly, since I treat CLL, I have made a slide that's specific for CLL, CLL Society, American Cancer Society, ASCO, NCCN, and CDC guidelines. And these guidelines do keep changing as we learn more about the studies. So please look at these. If you have any questions, you can reach out to us. And thank you very much for your attention. I'll be happy to take any questions.
Thank you so much, Dr. Bhat. That was incredible. I think it was a very good and humbling reminder how COVID just doesn't affect people with lung issues, but the whole community, right? So one question that I wanted to ask you, you had mentioned that unfortunately in the beginning, in the height of the pandemic, care unfortunately had to be delayed because of the concern for complications. And then now we're seeing that a lot of patients, especially for people who may be listening in or who are patients themselves, that they worry about telling their providers or the nurses and the staff about symptoms they may be having because they don't want to delay treatment. Because if they have a cough or fever, then they may not get their chemotherapy, for example. Could you speak a little bit to that? Just what would you advise to patients? That is it worth coming in to the cancer center, getting your chemo and not telling them your symptoms? Or is it better to wait until your symptoms are better and then get your chemo?
Yes, I think that's a very important question, given all the kind of information that's around us, especially with the flu season starting, there will be overlap in symptoms. So should a patient delay telling symptoms, or should a patient, so we will never advocate for a patient to not come up with their symptoms, whether they're on chemotherapy or they are expected to start treatment or they're on watchful waiting. There are many diseases where we do watchful waiting. But as you have seen from all these multiple studies, that the outcome of patients with cancer who get COVID are very, very dismal. 37, some studies said 37, 50% mortality rates. So please do not mask your symptoms or conceal your symptoms. Always tell your provider what is going on so that you will be guided appropriately. Always call before you come into the clinic, because we have to think about other patients also. But please, please, please let your provider know what's going on.
And then something related to that as well, unfortunately, sometimes in our political landscape, some people get blamed for different issues. So, for example, just recently, physicians were getting blamed for trying to say that patients have COVID so that they can get money based on that diagnosis. So just a point to reiterate that when you had mentioned that there were delays in the healthcare system, again, during the pandemic, was that because of healthcare themselves, the physicians, the staff, that they didn't want to take care of patients, or was it because of the pandemic and that we physically could not provide care for patients?
It was whatever measures were initially put in. People were not happy with the lockdown, or people were initially told not to wear masks. This was all because everything happened suddenly. No one was prepared for it. No one was ready for it. At that time, we didn't advocate masks because we were there was a huge shortage of PPE for the medical staff. So we were trying to preserve that. So no, there will never be a physician who will inflate the death of COVID just to get money. At the end of the day, we are seeing patients, we are exposing ourselves, we are putting our families to risk. So I would never say or try to amplify that voice. We always do. We always put our patients first. All those measures were put in to keep our community safe and to prevent our healthcare system from getting overwhelmed. We were not ready for this pandemic. We had to build up capacity, staffing, space. So that is why all those measures were in place at that point. And we may be getting there again because of the second wave. So we all have to participate in halting this disease as a community. We as physicians do our part, the community by wearing masks, social distancing, not having huge gatherings can do their part. And we will eventually beat this pandemic. Whether it takes 1 year, 2 years, or whether a vaccine comes or it doesn't come, we will definitely beat it.
Oh, absolutely. Thank you for that. A good, hopeful message. We are kind of at that 1 hour mark. So to not, at least just to not ask any more questions, but to give you guys the floor again, that if you want to leave some parting words, with the people that are listening in, just maybe some, just like a quick, your top few tips or something for patients, either for the community or for patients who are actively undergoing treatment. And so just what your tips might be for people to think about as we go through this pandemic, especially this second wave. Dr. Chaudhry, if you want to go first.
I think I'll say that to all my patients and everyone else, just take care of yourself, take care of family around you, take care of your neighbors, your physical health as well as mental health, and trust your doctors and providers.
Thank you, Dr. Chaudhry. Dr. Bhat?
Yeah, that would be I would second what Maria said. Be there for each other. We're there for our patients. Let our patients the community be there for each other. Let's take care of each other and get through it, especially through the holiday season. I know holiday is not the best time where we like staying isolated. We want to celebrate the year or whatever, our families, our relations, but the upcoming holiday will be a different one, but it will be a different one just because we want to have many more holidays to celebrate.
That's a great way to put it. Thank you both so much. We really appreciate it. One note I just want to say real quick is that we are very privileged to have one of our old board members, I should say, and a great contributor to IMANA is Dr. Khalid Ghazi. And so he is familiar with you, Dr. Bhat, and so he just wanted to say thank you to both of you as well. He has been instrumental for IMANA's legacy, one of our past presidents, and so he was very grateful for your guys' talk as well.
So I just want to say that I am, because of him, he's my mentor. Thank you so much, Dr. Ghazi, for joining.
And that's, what we try to do at IMANA, right? It starts with one people, then we try to move things forward and continue our legacy, continue the great work, alhamdulillah, that IMANA is able to provide. So you guys are just the next in line with that. So thank you so much. Related to that point, just a few quick points I just want to make towards the end of this is that, there's not only is it just COVID, but there's also a tropical storm that's battering Florida right now and North Carolina, Tropical Storm Eta. So our thoughts and prayers are going out to those people there. IMANA is working on climate change as well too. So please check out our website about that and the health implications that climate change is causing. And again, relating everything is kind of interconnected, that as climate change gets worse, that's how pandemics like COVID happen. And not only will we just need to rely on a vaccine or different medications like Dr. Bhat and Dr. Chaudhry mentioned, but we'll have to change a lot of our own behaviors to prevent the next pandemic from happening. The other point too that I just want to make to remind is that people who go through cancer treatment or who have cancer, you can't pick them out in the street or in the grocery store. So just remember that your behaviors, whether you don't wear a mask or you don't wash your hands or something or have symptoms, you could inadvertently hurt someone and not know what they're going through just by passing them in the street. So please definitely keep in mind for that. And one last thing, so Dukutsi thankfully reminded me is that, as we just saw, Dr. Ghazi knowing Dr. Bhat and I know Dr. Bhat now, all of that as the line goes, we do have a mentorship program at IMANA as well too. So we want to be able to connect people throughout the generations to help the next generations that come through. So please consider being a mentor. If you're a mentee who's interested, please sign up. And last, but not least, obviously, if you feel like you want to do more and you feel like you can't do enough right now, or just you've been staying home, you've been doing the right things, you want to do more, we always need help, with donations as well too, to continue this work that we do. And we are just so grateful for people like Dr. Chaudhry and Dr. Bhat, all our staff here for just doing this great job. And so please wear your mask, social distance, wash your hands, be careful during the holiday season. Thank you all so much.